thanks everyone for joining us today for today's webinar. Today we're focusing on the resumption of cancer screening programs following the COVID-19 pandemic. We don't need to contextualize too much. I think everybody's very aware of the situation, its impact and so on. But just to say a bit of background is that at ECL we've had several online meetings and so on the topic of the impact, immediate and thinking a bit more long term of the pandemic itself. And one of the key meetings that we had was for the cancer leagues, which was a couple of months ago now, during which we had presentations from a few leagues on their perspectives on certain areas, including prevention, early diagnosis, patient perspective, and so on. And during this meeting, they told us about their concerns and priorities. And one of the main issues that was recurring from several members, several cancer leagues and representatives was the issue of the impact on the cancer screening programs, which for understandable reasons have been either stopped or severely delayed by the effects of the pandemic. So for this reason, we thought, as we have great collaboration with the organizations represented by our speakers today, with CPO Piemonte in Turin, Italy, and IARC, the International Agency for Research on Cancer, we thought we'd take advantage of this good cooperation and connection to have a more focused seminar online to look in detail a bit more at this issue of the resumption of the cancer screening programs following the immediate aftermath of the COVID-19 pandemic. So I'm delighted to share with you today the opportunity to hear from some expert speakers on this very important topic. And I'm going to share now my screen, just so you can see the brief agenda. So we have here 4 excellent speakers across 3 interventions. We'll have Andrè Carvalho from the International Agency for Research on Cancer, who will talk about the general overview of the impact on the screening programs. And then we'll go more deeply into the situation with our collaborators at the Virtual Collaborating Center for Early Detection of Cancer in Piemonte, Italy, with Carlo and Paola, who will talk about the lessons learned throughout the resumption process of rebounding from the pandemic itself. And then finally, Livia, also from the CPO Piemonte, will talk about the communication needs and strategies in this new context that we have currently. Just some final housekeeping points. I guess you're all familiar with these elements from various meetings, both with us and elsewhere. But do let us know if you have any problems, either through the chat or through email. We'll be monitoring things to make sure that you can hear and that you're able to intervene through using the chat function primarily. There's also the raising of the hand, but we're monitoring the chat box, so through there you can answer and ask any particular questions. The webinar itself is recorded, so just to make you aware of that. And this is primarily for people who couldn't be available to join us today, because of course we're now entering into the summer period of vacations. So this is a given opportunity for others to hear the learning from the various presentations you'll hear today. So if there's any problems through there, just let us know. But primarily we ask you to make sure that the microphone is on mute and so on, and that you make use of the chat function. At the end of the presentations, so we have the 3 interventions which will take concurrently, and then we'll collect the questions and points for discussion at the end. So we have about half an hour or so for that, and there it will be possible for us to hold to give you the floor and hand over for you to be able to speak directly. But as we say, we prefer to make use of the online chat box function that's within the Zoom functionality. So it looks like everyone's online. That's a brief overview of the agenda and the background to why we have the call today. I hope you will enjoy it. This is really going to be very interesting for us to hear these perspectives. So without any further ado, I hand over now to Andrè for his presentation.
Thank you, Dave, and thank you so much for this opportunity and to be discussing, the COVID crisis and cancer screening. Just also turn off my video. So I was asked to bring a little bit, what would be the impact of COVID-19 on cancer care with focus on screening programs. But also, what WHO, IARC is thinking on initiatives on how to deal with that. You're going to see through my presentation that I'm going to bring more ideas and questions than answers at this point, as some countries or most of the countries out of Europe are still in some lockdown. So they're still dealing with the crisis. They're not yet thinking on the aftermath, on what to do when, the lockdown is finished and how to resume activities and how to prioritize. I think we're going to have a chance to hear from the Italian experience on that. So as we could imagine, there are going to be a lot of impact of the COVID or the cancer care. There are some multi-center studies showing that, patients with cancer might have a high risk for all severe outcomes, so they are more susceptible and to get infections and being, in the hospital facilities close to patients that are infected. There are also, studies suggesting that because of the lockdown and delays in treatment and so on, that we can expect an increase for at least 20% in cancer deaths because of the pandemic. And so this is kind of the broad consequences that we are seeing. When we go for the cancer screening, there is some evidence around the globe showing, in numbers, how this have affected the attendance and compliance to screening tests, right? So this is some information from the US in a database that covers over 200 million patients. And they say that they saw a 9% fewer colonoscopies during April compared to February or just before any lockdown in the US, 87% reduction in mammographies and 83 reductions in pap smears. And when you look at Europe, that reduction was 100% for many of the countries. So there was a complete stop in the cancer screening activities for a while in many of the countries in Europe. But even when you think about the US that, did not stop or tried not to stop, the patients are not going or the systems are not ready. Even there, you can see 80 to 9% of decrease. So regardless if you did a complete lockdown or you try to stay open or business as usual, it was practically impossible for doing it. The UK National Screening Program, right? It's the same thing. They officially did not suspend in England the screening, but then the NHS stopped sending out screening invitations. So this is kind of, a divided message, right? You did not suspend, but you're not inviting people. Anyway, they saw almost an 80% drop in breast cancer referrals in April compared to the April in the year before. And what they estimate in the UK for the first 10 weeks of the lockdown, almost 4,000 cancers that would be diagnosed through screening was not. Almost 13,000 fewer patients receiving cancer surgery, 6,000 fewer radiation chemotherapy, and almost 3,000 patients miss radiotherapy. So we can see that really, significant impact on cancer care. But what suffers more was the screening and all those cases that should be diagnosed through screening that weren't because of this, right? When you go to Europe, we can see that in many countries, the routine screening for breast cancer has been postponed, that some countries have reported insufficient capacity to cope with healthcare services that are not related to COVID. So in a lot of countries, not only in EU, many doctors from other services and nurses and health professionals, even the administrative people in the registration invitation were, helping with the COVID crisis. So when we talk about cancer screening, invite health people, asymptomatic people to do testing, that was kind of put aside for a moment, and people were redirected to work with the COVID crisis. And on the patient side, even as I showed in the US, that you would have this thing that you could continue doing the screening. A lot of patients have been afraid to visit healthcare services during the pandemic for fear of contagion. And in fact, you see some countries that are showing an increase in people dying at home for other disease, for non-communicable disease, chronic disease, because they actually stopped going to the hospital to take care of so many other diseases that they had, and they got worse and then eventually die at home of being afraid of going to the hospital for care and got contagion with COVID. Also, we have this report from the Netherlands, showing regarding the cancer cases, right? Showing that from February to March, there was almost 30% decrease in the in situ breast cancer cases and also in the invasive tumors. But also, in April, we could see that it worsening, that the decline on the detection of breast cancers, either in situ or invasive, was down by 50%. So what we can see as well is just not that, the patients who are screened are not getting screening, but, the cancers are not being diagnosed. And there is this issue about, people that were in between that got the screening test should go for further assessment and never get further assessment because of the COVID, right? So those are the high risk individuals. How does IARC and WHO work in this scenario, right? So IARC in particular have been doing some research in this intersection of cancer in COVID, and I put in bold some ones that have been, can be related to our activities in cancer screening particularly, right? So I'm gonna show a little bit about the Cancer Task Force from UICC, trying to understand the impact on cancer, including cancer screening. There are some surveys in Cancer Register worldwide to assess the impact, and that would include impact in the screening. We are doing some studies also in ethical implication of the pandemic, not only research, ethics in research, but also, ethics in patient care because of the pandemic. And also my group specifically, we are trying to look at the impact on cancer screening programs outside Europe in kind of this low, middle income countries that we work with on cancer screening to try to understand through a survey what is being the impact of the pandemic, but also how they are thinking of managing the aftermath or the resuming of the activities. I think the major, information from cancer screening might come from this task force that going to be this global modeling consortium that IARC is part, UICC is part. I know that Dave from ECL is also being part of the task force, and we can see that, from the participants that they have in the web page, that you have a fair representation from around the globe on that. And I know that International Cancer Screening Network is sending out surveys to try to understand the impact on cancer screening in the COVID, but no information to be shared at this point. So, so what would be the guide, right? So WHO unfortunately doesn't have a guide now for cancer screening. The guide that they have online talking about the essential health services that should be continued during COVID-19 pandemic does not include cancer screening, meaning that it's not listed as a priority, as an essential healthcare provision to be done, right? But I found this link from the Australian government, you know, for cervical cancer, trying to, you know, giving clear information on how to deal with cervical cancer screening, you know, during the pandemic and just after, right? So what you do with patients with symptoms of cervical cancer, with new screeners that just turned 25, with routine screener, with those that are overdue or never screening, you know, how can you include self-collection or self-sampling for this, but also they, you know, talk how to deal with the further assessment patients, right? Those that need follow-up testing and investigation. And then they try to divide these to prioritize, right? They say that there is 3 groups that we need to deal with that did the test and now need for the assessment. We have the intermediate risk are those that are HPV non-16 or 18, you know, and are negative or low-grade cytology. But then you have the management of the high-risk results, right? Those that are HPV 16, 18 positive or non-16, 18, but with high-grade cytology or worse. And also you have those that have been, you know, diagnosed with CIN 2 and 3 and needs treatment, right? So they kind of, you know, give very short and clear messages on how to prioritize and how to deal with the different population that we usually do in the screening setting, but also in the further assessment setting and so on. And to finish my talk, as we have so many uncertainties at this point, I saw this article that I thought I should just bring to finish, you know, that trying to see the good side of it, right? That is very provocative in how COVID may improve care, rethinking cervical cancer prevention. And then I begin to see, you know, that can we take this moment not only to see the impact, and, you know, we know that's there, but also, you know, as we are coming out and we are rethinking how to deal with those patients that were in the pipeline for doing screening, can we implement a few things that might really improve care, like take this as a window of opportunity. And, you know, by that, my comments that, you know, at EU, you have some countries that still offer screening for off-target age patients, right? So is it a time, as you have, you know, the number of screening tests that you can do and for the assessment that you do, and some of the population that you do that is off-target. So maybe if you decide to go, you know, just for the target population, you might be able to put some of those waiting patients, you know, faster in the track. Also, some countries offer a screening for cancer other than cervix, breast, and colon, right? So when you do those no evidence-based screening, you are taking out resources of professional workforce, space in the agenda, and also money. So maybe now is time to rethink investments in non-evidence-based screening cases, right? So to finish, for me, the take-home message at this point, and we are waiting for so many other information to come to help us to move forward after, as we are coming out of the pandemic and going, back to normal activities. It's really important for you to take this time and understand where you stand, doing a situation analysis and know your numbers, right? And then to create a plan, how to prioritize all this backlog patients that you have for screening tests, for further assessment, and with newly diagnosed cases, And maybe it's time for keep your focus on evidence-based screening, right? Stick with age range and tumor sites. Also, why not consider evidence-based innovations, right? Why not consider new algorithms? Why not consider self-sampling for cervical, to decrease? Or if you are in a program for colon cancer that's based in colonoscopy, why not move for a FIT test and keep all those colonoscopies for confirmation of the cases and rendering of the positive FIT test, other than trying to do colposcopy as a basic screening test. And in the end, again, thinking of a window of opportunity, maybe consider de-implementing the non-evidence in screening, right? So here I'm talking about the other sites other than cervical, colon, and breast. So finalize that, this could be a time of reflect among what we are doing, understanding it in the planning of getting back to the normal activities. Maybe we can implement some changes that can be very, important for the cancer screening program in the long term. With that note, I would like to thank you for your attention, and I'm going to be open for questions.
Thank you very much, Andrè. We'll take the questions altogether at the end, but it's very helpful to have those take-home messages summed up there in the final slide. It's very, very welcome. So thank you for your intervention. And now I'd like to hand over to both Paola and Carlo, who will take on next presentation.
Thank you, David. Thank you for inviting us to this meeting. Where is it? Here, probably. Okay. Okay, can you see the screen?
Yes, yeah, it's just starting.
Yeah, okay, thanks a lot. I am Carlo Senore. I'm an epidemiologist working at the Cancer Prevention Center in Turin.
You have to, Carlo, sorry, you have to double click to enter. It's just loading up, but we just have black screen at the moment.
Yeah, that's okay. Does that work?
No. No, I don't see it.
Oh.
If you stop and restart it, maybe. Yeah.
Let's see.
Ah, there it is. Great.
And here, okay.
That's perfect. Yeah.
Okay, that's just a moment. Okay. So sorry for this problem. I am also the director of the regional cancer screening program in Piemonte, and I will use the experience of our program to discuss some issues concerning the restarting of cancer screening following the COVID-19 crisis. And this is an experience that is common also to other programs in Italy, and it reflects also the recommendation that Andrè was just outlining at the end of his presentation. Just to have a context information, we are offering cervical cancer screening with pap smear. We are inviting women every 3 years in between age 25 and 29. And for women between age 30 and 64, we are offering HPV testing, inviting every 5 years women who attend screening, and every 3 years non-responders to screening. For breast cancer screening, we are actively inviting for biennial mammography women aged 50 to 69. We are offering the opportunity to participate in screening to women aged 40 to 49. They receive a leaflet informing them about the advantages and disadvantages of screening. And if they volunteer, they are invited every year for screening. Women aged 70 to 75 can call to fix an appointment every 2 years, but they are not actively invited. For colorectal cancer screening, we invite people aged 58 to perform a sigmoidoscopy, which is offered once in the lifetime. If the sigmoidoscopy is positive, they are referred for colonoscopy. Those who don't comply with the invitation with sigmoidoscopy are offered a FIT, fecal immunochemical test, and they are invited every 2 years until age 69. During the lockdown, we maintained, where possible, some activities which was aiming to manage a subject with a positive result at primary screening. Those who had been screened before the lockdown, they were offered the possibility to come and perform the assessment, even if some of them did prefer to avoid presenting for screening due to fear of infection. And also for those who had been referred for surveillance, for follow-up following a cancer or a diagnosis, and for early recall for people who need a screen at shorter interval. Primary screening was paused and people were not examined, but this might result in a later diagnosis, delay in the diagnosis of cancer, so a more advanced cancer stage diagnosis. We, for example, estimated that we missed about 45 colorectal cancer and 250 breast cancer during the lockdown. They were not diagnosed as compared to the previous year. And given that the activity is starting again, but a very low volume of activity, about 40% as before, if we cannot change this trend, we will miss an additional 50 colorectal cancer and 150 breast cancer by the end of the year. So screening cannot be postponed too much once clinical and diagnostic activities can be restarted. But planning the restart requires some thinking, some planning. And the principles we are following when planning restarting are mainly safety, the gradual and phased recovery plan, the definition of a plan, monitoring, and the communication. And the communication will be presented by Livia later, and I will address the other point with Paola. The main point in the planning is to involve health professionals in the discussion of which are the standard protocol which should be implemented or modified now during this restarting phase. It's important to pilot the feasibility of the procedures we are planning to introduce, and we are planning a gradual increase in the volume of activity as we manage to be more efficient in performing the examination using the new, respecting the new requirement, using the new protocols. And of course, one of the options to try to catch up with the delay is extending the opening time of the screening services, but it depends on the availability of resources. With respect to safety, we have to take care of safety of health professionals during the screening examination, and so they need to be to have access to adequate supply of personal protective equipment, and also we need to define the minimum requirement for each kind of test for primary screening, for example, for cervical cancer screening as opposed to mammography, or eventually to colonoscopy for assessment for a FIT positive patient. The requirement might be different. We should try to harmonize the requirement across the different local programs to avoid waste of resources. The personal protective equipment are were not so widely available during the crisis in Italy, but maybe also in other countries. And also, we need to protect the screening participant. We need to ensure that we have COVID-free facilities and clinics. We have to change the invitation strategy. There's an opportunity to rethink our invitation strategy to reduce the number of people in each screening facility. So we need to fix the appointment and to have a distance between one appointment and the other. And we might explore the opportunity, the option of offering other approaches to screening, like for example, self-sampling for HPV, as already Andrè was mentioning. Improving or extending this approach might, of course, facilitate the access to screening without any risk of infection. Then to the access to the hospital facilities, we are planning a triage, but at the moment we are not requiring COVID testing for people coming for screening test. And of course, we need also to have the available personal protective equipment for people attending screening. So we have to plan also the supply of this kind of equipment to each screening facility. And monitoring, as we have said, we are planning a gradual restarting, and this requires monitoring of activity. This is the timing of appointment and the time slot for each exams to monitor the availability of resources and the possibility to catch up with the delay. We need to monitor the efficiency of the activity and the utilization of resources, for example, monitoring the proportion of missed appointments and trying to identify the reason for the missed appointment to eventually plan intervention in terms of communication, and we'll see after how we can manage. And we need to monitor delay in primary screening invitation, because at the moment most of people are expected to have a delay of 4 or 6 months, but if the activity will not restart at a high volume, this delay might increase. And of course, also the interval between positive screening and assessment. We needed to modulate the number of invitations at primary screening so that we can avoid bottlenecks in terms of second level assessment for positive subjects. Waiting time cannot increase too much, because after that also the stage distribution of screen detected cancer might be worse if the delay between positive result and assessment is higher. For example, for 9 months, there is evidence for colorectal cancer screening, for example. And we need also to monitor the outcomes. The main outcome, of course, is participation in primary screening and follow-up. And again, here, this monitoring is something that can provide information for planning communication strategies. We need to monitor the detection rate of pre-invasive and invasive lesions, and stage distribution of screen detected cancer, which is the outcome which might be mostly influenced by the delay. All these monitoring activity is meant to be on a regular basis and nearly real time, to be able to timely address problems and to provide and propose solutions. So we are developing new system for monitoring screening activities at the regional and national level. Then I will leave the floor to Paola now for some solution that we are proposing, and then I go back to the last part, a couple of slides to discuss about lessons we can learn from this emergency. Thank you very much, and I come back after Paola. Okay.
Okay. Thank you for the invitation. I hope you can see my screen.
Yep, you can enlarge it if you want.
Okay. Okay, so I will present some proposals of priorities for invitation we are now considering when restarting the activity for screening. We can consider 2 options to invite first people who receive invitation but who could not participate because the activity was stopped. Or then we consider to adopt priorities criteria for invitation in order to optimize the use of limited resources, allocating them to people who can get higher benefit. As for colorectal cancer screening, it is very important to optimize the utilization of the endoscopies resources. And it could be done designing tailored strategies based on advanced neoplasia and interval cancer risk. A very interesting option is offered by FIT because this kind of test can quantify the fecal hemoglobin, and this quantitative nature could be a very important option to tailor screening strategies in order to module the referral to total colonoscopy. Some recent studies shown the association between the fecal hemoglobin concentration at first screening or over 2 consecutive negative tests with the screening outcomes, which are the detection of advanced neoplasia, advanced adenoma, and colorectal cancer at a subsequent round. So we can consider the concentration of the fecal hemoglobin over 2 consecutive rounds, even if the result is negative. And according to results from recent studies conducted in the context of large population-based programs, we can identify 2 subgroups of people with different risk at subsequent tests. So subjects with a cumulative fecal hemoglobin level higher than 20 micrograms per gram of feces over 2 subsequent rounds showed a higher risk for advanced neoplasia and even higher for colorectal cancer compared with subjects with undetectable fecal hemoglobin at the 2 previous exams. And these subjects with higher level of cumulative fecal hemoglobin showed a higher risk also when compared with the subjects with a cumulative fecal hemoglobin in the range of 15 and 19.9. So these subjects represent the 50% of the overall screened people, and they showed also a very low cumulative detection rate of advanced neoplasia and colorectal cancer at a very long interval of time since their second fit. So we can consider to offer a longer screening interval. This approach might result in a more appropriate and more efficient utilization of the endoscopy resources and can permit to reduce unnecessary assessment. But it is important to develop effective communication strategies in order to inform these people in reason of the prolonged screening interval. And we are now considering this option and trying to introduce it in the program through a randomized control trial. As for breast cancer screening, we decide to give priority to the invitation of women who are included in an oncological follow-up process or need rapid assessment, to reserve a quota of the activity to spontaneous participation and to reschedule the invitation according to the originally deadlines. But also we activated a working group aiming to evaluate possible alternative criteria in order to define priorities for invitation based on risk. First remains the priority to invite every 2 years women in the age range 50-69 in reason of the evidence of a net benefit for this age range for the screening and the impact on the mortality. But we are considering and we are assessing the feasibility of the possibility to prolong interval for women in the age range 55, 45, 49 and 70, 74 women. As for cervical cancer screening, we suggested a list of invitation priority criteria that should be combined with the invite of women who had already received an invitation cancelled for the emergency. And so, first of all, we decided to invite women with indication to repeat HPV test after 1 year, a previous HPV positive and negative cytology, because we do the triage for HPV testing with cytological test. Then we decided to invite women with indication to repeat the test, women with indication to HPV or pap test repetition after colposcopy. Then in the list we have women invited to the next round following a second level exam, women enrolled in ongoing studies, then women close to 65 years of age in order to permit to these women to have a last exam with an HPV test. Then women with previous screening pap test, and last, women invited to HPV after a previous HPV negative test. So we created this list according to the risk of the detection of pre-invasive lesion. It is a strong recommendation to introduce HPV with a 5-year interval in programs which are still using a pap test every 3 years. And as Carlo said, there is the assessment to introduce the feasibility of introducing the use of cell sampling, and also to prolong interval from 5 to 10 years for women vaccinated against HPV. So I stopped here, and I give to Carlo the word.
Okay, thank you, Paola. Just to conclusion, as already mentioned also by Andrè, this might be an opportunity to learn something to rethink screening. And one of the main issues that is under discussion is the incentive to improve the utilization of limited resources, to improve appropriateness of resources utilization. There is now a tension between organized screening and clinical activity, and as both activities are competing for the same resources, and to maximize the benefit of reduced capacity, as we have seen just now in the presentation from Paolo, we might use a priority criteria to optimize the utilization, to have a more efficient utilization of resources, screening those who are at higher risk, and reducing intensity of screening for those at low risk. And another issue is also reducing both in clinical and screening activity unnecessary examination and controls. For example, intensive surveillance protocols in colorectal cancer screening, which are wasting resources. It was estimated that about 36% of colonoscopy performed in endoscopy screening unit for follow-up are inappropriate. So that's an opportunity to improve the appropriate utilization of resources. But we also learned that healthcare resources can rapidly be overwhelmed during a pandemic, and if screening is not considered an important component of healthcare and that there is no prior planning, then policymakers may ignore it when responding to an emergency. Available screening staff may be, and in fact it was, redeployed to acute services, reducing the availability for screening activity, or they might be infected, so they might need to stay at home or to be isolated, and this will again reduce resources, and that this should take into account when planning the response to emergency. But of course, the shortage in resources and the budget constraints and the increasing cost of care were already undermining the performance and sustainability of the system before this crisis. We should take into account that cancer screening reduces the need of intensive, invasive, and expensive treatment for patients with advanced disease, so it might favor sustainability of the programs. And the impact COVID pandemic has markedly increased the pre-existing constraints and makes screening more instead of less relevant. This is the take-home message, which is important. Screening should not be paused, should be implemented, because it will allow a better use of limited resources and reduce overall cost. Thank you for your attention.
Thank you very much, Carlo, and also to Paola, and excellent presentations. They're really comprehensive summary, a lot of detail, but very accessible. So really, thanks very much for the explanation of your situation, how you're responding with the adaptation of the programs in your region, and also some indication of joint working with other regions in Italy. And also for those final points, they're very important about the ability of organized, effective approaches in cancer screening that can help improve the situation by making better use of the resources. And this is key message, I think, to take away from that presentation. So I give the floor now to Livia for the final presentation.
Yes, thank you. I have just to find my presentation. Sorry. Where is? Can you see?
Yep.
Okay. Okay, so thank you very much for the invitation. I'm Livia Giordano, and I am a medical doctor epidemiologist working at CPO Piemonte, like Carlo and Paola, and I am responsible for the screening and epidemiology unit of Curie. So I will share with you some consideration concerning communication in cancer screening, especially in this very particular period. And I will focus my attention before, during, and after the COVID-19 epidemic, how the communication has or will change. All this consideration has been made within an Italian inter-screening communication group, which is a group which involves many professionals, screening operators, actively working in the 3 screening programs of breast, cervical, and colorectal cancer. So I think that we must remember always, not only in this period, that timely evidence-based information is very important and should be considered in all our action, and is the best vaccine against rumors and misinformation. This is even more true during the COVID epidemic, and so we must follow this consideration. So before the COVID-19 epidemic, communication and screening has been a long debate, because we think that in the screening context, we must remember that in the screening context, health professionals approach healthy asymptomatic population for the screening test, and so our communication must be very special, in the sense that we need to respect the patient's autonomy. That means that we must respect the right of people to decide if accept or not the screening invitation, and also we must accept their refusal. And so we must also be aware that all our communications action should be in line with this ethical principle, like autonomy, beneficence, do not harm, and justice. So in the screening, let's say before COVID epidemic, it was very clear that it was imperative to communicate within the screening programs in an appropriate and unbiased manner, mentioning both hazard and benefits of the screening procedures, in order to reach and inform participation about people attending screening, And this is even more true now, during and after this COVID-19 crisis. There are different moments and different actions for communicating and screening, starting from before the screening program, in the planning phase of the screening, during the mass campaign, but it's very important, of course, the communication when we invite people for screening tests. Of course, also the communication about the need of further assessment, or in order to give the results of the screening procedures, or inviting for therapeutic pathways is very, very important. We must remember that our communication also in this period is a communication not only addresses to the screening target population, but it's a communication that should involve all the other actors involved in the screening process. That means the family of people involved, the screening units, the GPs, who are playing a very important role, especially in this moment, all the screening health operator, but also the association, the advocacy group, the institution, the media, the foundation, and the general population as a whole. So in the past, one of the most, let's say, important challenge was how to shift from a promotional approach to screening to a more balanced information in order to support his informed participation. And in the past, we have used a lot of communication tools in order to reach this goal, like letter, pamphlets, brochures, website, etc. But also we have to remember that when we speak about the screening population, we are speaking about a very heterogeneous population. And so also in our communication approach, we must take into account the different characteristics of this population, and so the different needs, like for instance, the different needs compared to the age of the people invited, the gender, the cultural levels, the presence of hard-to-reach subgroup of the population. And so our communication before, but also now, should be clear, comprehensive, transparent, and honest. And here are the main characteristics of the communication that we have tried to follow in the past in order to provide people with a very high-quality communication approach. So the communication should be accessible, relevant, comprehensive, tailored, phase-specific, and multi-level. But what happened during the COVID-19 epidemic? Of course, as already mentioned by the previous speaker, it was a very particular period where, of course, all our medical procedures, including cancer screening, were put on hold to prioritize urgent needs for the crisis, for the COVID epidemic, in order to reduce the risk of the spread of COVID-19 in healthcare settings. And so, as we all know, there was a substantial decline in cancer screening procedures. And so what I hope all of us had done during the pandemic in the past months was to explain very well the reason to stop the screening, and to whom we had to explain this reason. To people who would have been invited in this period in order to reduce their distress. To screening professionals, of course, they must be updated on what was happening. GPs, screening target population, and also the general population. What we have used as a communication tool was phone calls. We tried to contact all the people involved here in Piemonte, for instance, in the incoming invitation for screening, in order to say that the screening has been stopped, and so they have to wait further contacts from the screening units. But also we tried to contact also GPs in order to inform them why the screening has been stopped, and also to try to cooperate with them in order to carry some very important message for the population. For instance, as Carlo already mentioned, that the second level and treatment activity should continue to be carried out, and so all people with abnormal positive results was followed up during this period. And very important, in order to underline that any sign or symptoms during that period had to be, let's say, had to be communicated to the screening program or to a healthcare provider for a consultation. And again, very important, what we communicated at the time is that we hoped at the time that the stop was temporary. Here's also some example I found in the web. This is, for instance, the communication made by the public health ways for what concerns screening programs, where again they explain the reason for stopping the screening, and also that the suspension was temporary, and they promised at the time to do all their best in order to give further communication on a future step of the screening. Here is the communication made by the Cancer UK Research. They have a national screening program, and again, in their website, the screening operator communicates also how it was difficult to communicate this kind of message, but it was mandatory to do that. And again, they at the time reassure all the population that all the measures in order to make sure the screening procedures and the restarting of the screening have been put in place. After the COVID epidemic, after is not white, is gray, because we have to wait what will happen in the next months. And so some countries are, in my opinion, mandatory, but to say some things on what we have to do now that we are, let's say, in the post-COVID phase. I think that we must consider communication as an instrument of restarting and not a necessary aspect of the reorganization of screening. This is a statement from WHO, where some months ago, before the start of the phase 2, where it was written that communities must be fully informed and aware, involved, and prepared to adapt to this new normal now, because we are facing with a new normal. And so, following these WHO criteria, I think that the goal of communication in this phase 2 is to provide both users and healthcare professionals with complete and good quality information. And so again, what we have to communicate in this phase, we have to communicate the reasons supporting the decision to restart, the conditions that make the restart possible, let's say all the safety measures put in place in order to guarantee the protection both of user and health professional, the new invitation modality as already mentioned, and any priority criteria already mentioned before for inviting people. We have to involve in this communication, of course, people invited in the next months, but also all the professional, health professional, GPs, and the general population, using different communication tools. First of all, we have to communicate that safety measures have been adopted to limit the contagion of COVID-19, and that we guarantee the maximum security, for instance, with the sanitization of tools and premises. Of course, we have to communicate also that our appointment now will change, because now we must respect physical distances among people. And so the appointment, we will adopt longer appointment time in order to avoid crowding in waiting rooms. This is very important. We have to communicate that we will need to make some triage for COVID-19 before screening appointment. And so people must be ready to do that and to accept to do that. We must communicate the limitation on visitor other than patients or their caregivers into the screening facility. And so also we have to communicate that it will be mandatory to wear some face mask or face covering during the screening exams, and that hand washing and the hand sanitizers must be very frequent for staff, for patients, and also for visitors. And again, our communication must follow the same rules as before, must be clear, complete, and transparent, and our tone must be calm, reassuring, open, without paternalism. And again, we have to try to have our communication tailored to the different screening levels. If we are dealing with first invitation or second level invitation. And again, communication must be timely, flexible, and ready to adapt quickly. And this is a very important lesson learned for the COVID period. But also in this field, we have some lessons learned from the epidemic. Because despite this tragedy, the COVID-19 pandemic gave us also the opportunity to learn something and to change some things. And Carlo and Paola already spoke about different screening procedure, access sampling, telehealth, etc. This is an example from Africa, where people working in screening are trying to use different screening approach in order to facilitate the participation in screening. But also maybe we can take this opportunity we have in order to change maybe some things also in the field of communication. For instance, we can accelerate the adoption of more suitable communication tools. This is something very important, I think. We are used to use also always very, let's say, old-fashioned communication tool like a written letter. Now we have experimented that use WhatsApp, phone calls, text messages can be done. Of course, we must invest on training, instrumental equipment, and very important, we have to compliance with the privacy regulation, which is a very hard topic. But in any case, we have learned that we can change also our communication approach, and we can adopt maybe a more efficient and a timely communication style. Again, I think that one of the main contents of the communication in the next period is to regain people's confidence in screening. So again, we have to share the impact that security measures will have on the timing and method of screening. We have to strengthen the sense of individual responsibility and self-determination, and also the responsibility related to the optimization of the free screening offer, in the sense that it's essential that for people, it's important maybe to inform us if the intention is to participate or not, in order to give other people the opportunity to take an appointment in case they refuse our invitation. Of course, the health professional is another target of our communication, because again, I think that we must reassure also healthcare professionals about all the adopted security measures, and also to find maybe new ways in order to motivate them in the post-lockdown period. We have to remember that for many healthcare operators, so also for the screening operators, the lockdown period was a very stressing period. And so now we have to, I think, reassure them and to remotivate them. And we have also to restore the meaning of cancer screening in these operators, and also to involve them in all the different adopted screening strategy in the next period. To share with them, of course, the new strategy, but also to have their opinion and to get their opinion and their point of view. I think that one very critical message in this period is the risk of the delay in early diagnosis of cancer. Of course, we know that screening aims to find cancer early before there are symptoms. And of course, what will happen in people who was delayed because of the epidemic? I think, but this is my opinion, we can discuss that for the general population, a delay, if short, for people without symptoms, probably if the delay will be maintained short, it's probably that there will be a long impact, a great impact on cancer incidence. But it's very different approach if we are considering individual persons. And so I think that the main message is, of course, apart to try to reduce the gap, the delay, we must underline frequently that people should pay attention to any symptoms that may arise while they are waiting for the next screening test. And this is an example on how we can, let's say, face with these very, let's say, important questions. What happens if I can't get my test? I can't get my test for a while, or what happens if I have cancer? I don't catch it in time because of the delay, and I can go somewhere else. And so I think that health operators involved in screening should maybe follow and to be prepared, to be ready to answer to this kind of questions. And at the end of my presentation, I will focus the attention of the important role of cancer leagues. I think that the function of advocacy groups in cancer screening is increasingly essential. And in the recent year, the role of advocacy groups was very important in order to empower women to evolve from the position of passive participation to influential partners. And this was very, very a great, let's say, role of advocacy group in the last period. And so cancer leagues in Europe, we know, are playing a very important role in the management and delivery of cancer screening services, in the promotion of screening to target groups, but also in the monitoring and evaluation of cancer screening program. And so the role of cancer leagues in this period, during and after the COVID-19 epidemics, I think it's very important in explaining the reason for stopping cancer, sharing these communication aims also with the screening operators, supporting the decision to restart, restoring trust between users and screening programs, increasing the knowledge and the new adopted procedures, and reassuring about the impact of the temporary stop of screening activity. And so advocacy groups and cancer leagues can, I think, fruitfully collaborate with cancer screening programs in disseminating this kind of guidelines and recommendation, and in increasing the sensibilization of the population about the importance of early diagnosis and cancer screening, again, also in this period, following all the, let's say, communication issues mentioned at the beginning of my presentation. And so promoting an active participation and informed participation in cancer screening also in this period, and continue to provide specific services and cancer advocacy. Last but not the least, I think that another important role of Cancer League is lobbying, their lobbying action at the European national level, sensitizing policymakers and others and all the other stakeholders involved in cancer screening in order to restart as soon as possible, and in order to restore the previous workforce at least, and if necessary to make available additional support to make up the lost time. And this is my last slide. This is an example of, for instance, information that could be included in an invitation letter or in a communication strategy, where I think that the main part of the communication in this period, the main characteristics are present, like we have to explain why the stop, why we was forced to stop the screening. We must have transparent communication and maybe not to be afraid to confess fears, difficulties, doubts. It was not an easy decision to stop the screening, and we must also maybe have the courage to confess such kind of difficulties. We must communicate changes, priorities, as mentioned before. We must, of course, communicate about security procedures, and of course, we must again be transparent in communicating honestly the way things are and the reality of the situation. If now we cannot invite all the population because of all the problem mentioned before, we must communicate this kind of messages. And we must, of course, looking for cooperation from the population, the people we are invited for screening, and from all the community. So thank you very much for your attention.
Thank you, Livia, for a great presentation there, and also for taking the time to finish with those important points on the role of the cancer leagues in various aspects related to these issues. So now we have 15 minutes or so for discussion, for questions and answers with all of the panelists from all of the attendees still with us online. To do so, you can write directly into the chat function, or you can raise the hand in the participants button. But whilst you're thinking of some points to raise, we'd be interested to hear, for example, the specific challenges or experiences you have in your country or region as a cancer society, and also to take opportunity to bring that into the discussion today, to compare with what we've heard from the example, especially in the Piemonte region of Italy. But whilst the attendees are thinking of some questions, just to come back to this main point we were discussing previously, and was very well highlighted by Livia, and also in all the other presentations too, is about the restoration of trust in the general public. And the one issue that came up from our previous webinar with the Cancer Leagues was, of course, as Andre's presentation reaffirmed, there's only 3, let's say, evidence-based screening program for 3 types of cancers at the moment: the breast, cervical, colorectal, as recommended. But of course, what about the other cancers, the other issues beyond that? This is also an issue where people symptomatic with the early warning signs of other cancers also need to have the communication and trust to be able to go to present into primary care, etc. So are you working, as an open question, but the communication to people who would be receiving or expecting the invitation or the offer of screening is one thing, but are you also working in this perspective of ensuring and trying to restore trust more generally in the general public for the population with any sort of general warning signs or symptoms to be able to go back to into a clinical healthcare setting? Do you have this collaboration, or is it mostly within the confines of the screening program and your target populations within there.
If I can say something, of course, as already mentioned, for me, one important point, very important point, is to restore this trust between users and, let's say, screening operators in general. It's very important. And again, I think that the role of advocacy group is very important in this context. I think it's not a matter only of screening, but it's in general of all the health sectors. Maybe we have to rethink some things, but I think that the cooperation and the involvement of all the stakeholders in this, let's say, restarting phase is very, very important. I don't know if Carlo, do you agree with this?
Yes, I think that is it's important. I think that is one point that came out from all the presentation was that this is an opportunity to rethink the offer of early diagnostic tests and to focus on those who are most appropriate in terms of kind of screening and target age range and so on. This might be perceived or from some people as some sort of rationing of reducing the offer. I think it is important that also with the support of cancer leagues and anyway with communication campaigns, this message is appropriately framed to show that we are in fact taking care of optimizing the impact of screening to optimize the harm benefit balance, and that is in the interest of people to avoid, for example, too intensive surveillance program, for example, where you are invited to repeat unuseful examination which are exposing you to a risk of complication without any benefit in terms of reduction in the risk of cancer. These are messages that, I mean, it's difficult, I mean, because now they appear to be related to the reduction in resources or relative reduction in availability of workforce and so on. But in fact, that's an opportunity to replan again the activity and to, in fact, promote appropriate intervention and avoid unnecessary intervention that are associated with a risk. And this point should be highlighted in every channel, with every from all stakeholders in the place of screening, but also in clinical activity, because to get more resources, also clinical activity should be reoriented to offer the most appropriate services without promoting either unuseful early diagnosis screening, which are not or too frequent, too intense surveillance and so on. Also in the clinical sector, it's the same message should be conveyed.
I might add something there. You know, I think even though we are coming back to our normal lives, I think business and as usual will not be no longer the standard that we had before the pandemic. We are rethinking our way to work as we all were forced to telework. We are reviewing the way that we socialize, right? And it's going to be just a matter of time for us to, you know, see how cancer screening is done and all the professional interaction is done. There are fear at this point. Communication is essential, but also we're going to suffer a lot of resource limitations. A lot of money was spent in the COVID, so you know all the countries are suffering a very economic burden. So we're going to be less resource. So we're going to be less money to buy overtime for professionals to see more people. So I don't think a lot of the service is going to be able kind of to see the backlog of patients that were not screened while doing normal volume of the screen for those that are, you know, in time to come for the next round. So we need to think on how to optimize that. And these pass to, you know, prioritization, more evidence-based, changing tests, in focus on the target population. I think we need to rethink the way we are doing cancer screening. And I think this can be a good thing. You know, we can see on the bright side that it might be a time that we can be more efficient with our cancer screening. And maybe in the future, this means more people getting screening correctly.
I completely agree.
Yes.
And I think that a very important lesson learned from this period that we can change also very rapidly, and maybe we can improve, and also that maybe sometimes our aesthetic way of working can be changed in a fruitful way. And so we can change the approach, we can experiment new approaches, maybe more efficient. And so for me, also, the lessons learned from this period are very important in order to improve and to change our behaviors also in the screening context. It's a good lesson.
And in regards to the adaptation or modification to the protocols and different tools or approaches that will be used in the spirit of making the best use of the resources available, are the existing guidance, either European, national, or even at international level, is there existing evidence and guidance to support the rapid, let's say, adaptation of the existing protocol, existing setup, etc., to be able to react to that? So, for example, you're mentioning with regards to moving towards self-sampling in HPV for the cervical screening test, potentially as an additional tool to be used, where it may already not be widely used within a particular region or country and so on. But all these modifications that could be used, which I agree is a positive to take out of the situation in terms of making a better, more effective, more efficient program overall. Is there enough evidence and guidance to support how to do that, how to manage and evaluate it, or is it lacking in some respects, and we're going to see some kind of natural experiments in different regions and countries of different ways to adapt to this?
Yes, there are, Andrè already mentioned one international initiative about global modeling, the Global Modeling Consortium, trying to estimate the impact of the COVID crisis in different countries using different models, cancer screening models that are available in Europe, in Australia, in the US. But there are also other initiatives focused, for example, on standardizing the monitoring activity in different programs, so that we can get comparable data from different programs and suggest which are the most relevant indicators to be monitored in this phase, to monitor the restart of the activity, so define eventually new indicators, but shared among different programs. And of course, also in terms of the kind of protocol that can be adopted, there are international groups for colorectal, for example, but I'm not sure about also the breast and cervical cancer, which are already working, discussing potential options for ensuring a higher efficiency, reviewing the evidence, the most recent evidence, to suggest how you can redirect the resources to the most efficient utilization to identify higher risk group and those who are at low risk who can be delayed and postponed, or further postponed screening.
David, if I understand, I think there's 2 points to your comment that, you know, one is that I think there's so much evidence based on what works for the screening out there, you know, and you have the European guidelines and also the IARC handbooks, you know, in colon breast, and WHO is reviewing for cervical, and IARC is reviewing for cervix, because this is kind of old. And I think, you know, a lot of the programs, even today, are not using what have been set as a standard for a long time. So this is the issue. You can, you know, even before waiting for all this new evidence came, you know, you can align your program for what is have been an evidence so far, and this is a quick fix. The other part is what Carlo, you know, and Paola mentioned, is that there's even that evidence is being reviewing in the face that you have a struggle now with a backlog of patients for screening and for the assessment. And then you have international associations plus professional associations, right? The International Federation of Colposcopists and things like that, try to see, you know, new algorithms to put in the fast track, right? But I think there is one quick fix, is just take a look at the guidelines out there and align your program to that. This is something that's no brain. It's kind of, you don't need to wait too long, because those are very standard and they will not change that. What the new evidence is going to come is how can you fast track, or how can you fine tune what is there already about evidence. So I think there is those two layers that people can work with.
Mm-hmm.
Yeah, if I can add just a very little comment, is that my opinion is true, because I agree that there are a lot of screening programs maybe not following the most recent recommendation from the European guidelines, for instance, on cervical cancer screening, adopting HPV test instead of PAP, etc. But if I well understood your question, David, for what concern maybe new approaches not considered in the guidelines, because there are no yet a scientific evidence like for the self-sampling, where the evidence is present, but also in certain conditions, etc. Maybe we can use this period just to experiment, maybe in a scientific context, let's say, with a scientific approach. We can experiment in order to accelerate the process of adopting new strategy, because we are let's say, forced to do that, because we are in a context where we are forced to find a new, let's say, invitation strategy, new alternatives, and in this condition, maybe this is, let's say, a positive effect of the COVID period, because accelerates this process.
Mm-hmm. Thanks, Livia. Yeah, I agree. I think it's really an opportunity to explore things within the realms of what we know, and then testing out these novel areas potentially in this more controlled setting, and could again lead to better, more effective programs as a result. So we've come to the end of the time. Thank you everyone for the fantastic and very comprehensive presentations. I think they really answered a lot of the existing questions that we had going into this webinar. And it was really excellent to have the overview from Andrè, and then going more deeply into your experiences in Piemonte. And I think that also the take-home messages that you've given us have been really important and resonate a lot, that we have to, on the one hand, communicate and restore the trust with the general public, but then also to communicate to the policymakers, decision makers, about the centrality and importance of the screening programs in this new context. And then the key thing for me as well, the really substantial point, is this opportunity then to build on and improve existing practice, sticking first to what we know. As Andrè was saying, there's already well-established practice that's not in the guidelines, that's not being taken up as fully as it should be. So there's a quick win opportunity there, as he highlighted, but then also, as Livia was saying, this opportunity to experiment a little bit with new tools and methods that are perhaps not yet fully reflected in existing evidence and guidance. So I think it's given us a really excellent basis on which to work with for the future in this topic, and we can hopefully lead to better, more effective and accepted cancer screening programs as a result. So thanks everyone for also attending and sticking with us for the full webinar. The recording will be shared with all the leagues, and then also we will disseminate it more widely in a short format. And then with the consent of the present presenters, we'll share their PowerPoint so you can see the detail that was given in the PowerPoint. You can see them again and pick up those key points there afterwards. And there'll also be a very short summary that will follow with that. But as we encourage people to rewatch the lecture online and to look at the slides, they won't be so comprehensive, because we think it's really important to you to see the full picture here, because I'm very happy and proud of the presentations. They give a really good, clear picture, and it's extremely welcome. So thanks everyone for your time today, and have a good afternoon and weekend.